There's a woman I want to start with. She's 47, works full-time. She takes pretty good care of herself. She's been seeing the same primary doctor for 6 years. Last March, she moved to a new city for work. First appointment at a new clinic. They handed her a clipboard, every medication, every allergy, every surgery, every procedure, all of it, reconstructed from memory. Her records couldn't just transfer. 3 separate electronic health record systems were involved. None of them spoke the same language. She had no way to carry her own history with her. No way to verify what got sent. No meaningful say in where it went next. She filled out the forms. She got her appointment. She went home. And she had no idea that her prescription history had been purchased and resold multiple times without her knowledge since 2019. No idea that her lab results were anonymized, bundled, and then fed into AI models she'll never interact with. No idea that the sleep tracking app she used for 2 years sold that data to a health insurance modeling firm. She's not a data breach victim. Nobody hacked her. This is just how the system was designed. So the question is whether that's a design flaw someone should fix or a design choice someone is benefiting from. We're going inside healthcare today to answer that. 3 levels: the individual patient, the small practice, and the large health system. The extraction problem looks different at each level, and so does the answer. Let's stay with this woman for a moment. Her health identity is fragmented across roughly a dozen separate systems. One portal for the hospital, another for a clinic, a separate one for labs, another one for prescriptions. Some of it she can view, some of it she can print. Almost none of it belongs to her in any meaningful sense. The current model was built around the institution. Data lives where the transaction happens. Your history, your records, the most sensitive personal information, it belongs to whoever owns the system that recorded it. Think about what that actually means. Every time she described a symptom to a doctor, every time she agreed to a test, every time she filled a prescription, she was generating real signal about a real human life. And that signal is extraordinarily valuable for pharmaceutical research, for insurance risk modeling, for AI training, for population health analytics. She generated all of that value. The current model gives her a patient portal in return. But in a human-centric model, her health identity travels with her because the identity belongs to her at the infrastructure level. She holds it. She decides what to share, with whom, and for how long. A new provider needs access, she grants it. That access is no longer needed, she revokes it. And when her anonymized data contributes to research that improves outcomes for people with similar histories, she participates in that value. Consented contribution with terms she agreed to. That is a fundamentally different agreement between a person and the system that's supposed to serve them. Now, step back from the patient for a moment and look at who else is getting extracted from here, because the individual is only one level of this. Meet Dr. Marcus Webb, family medicine, mid-sized town outside of Fort Worth, Texas. 2 physicians in the practice, and he's been seeing patients in that community for 11 years. He's paying roughly $31,000 a year to access the EHR platform running his practice, and that platform is collecting structured clinical data from millions of patients across thousands of practices like his. That data is extraordinarily valuable for pharmaceutical research, for population health modeling, for insurance risk adjustment. Dr. Webb pays for the system. His patients generate the data, yet the platform captures the value. He's in the same position at the woman at the clipboard. He's funding infrastructure that extracts value from his work and his patients' lives. And what he gets back is a scheduling tool and a billing module. In a human-centric model, those economics shift. The practice owns the clinical intelligence generated inside its walls. Consented patient contributions stay attributed to the practice and to the patient. If that aggregate data contributes to a population health study, for example, the practice participates in that value. If insights from their patient population help a pharmaceutical company model better treatment responses, That's a transaction with terms, not an invisible extraction. The practice moves from being a tenant to a stakeholder. And here's where this loops directly back to that woman at the clipboard. When the practice has real skin in the game on outcomes, when the value they generate is tied back to the clinical decisions they make and the patient relationships they build, the incentive structure changes. The current model rewards volume and procedure codes. It doesn't reward long-term patient health because the platform captures the value of that data regardless of what the clinical relationship looks like. When the practice owns what it produces, that connection between data and outcome stops being invisible. The practice is now motivated by the same thing the patient is motivated by: better information, better continuity, better results over time. That's the incentive realignment that better clinical outcomes have always needed. And it doesn't come from a policy change or some federal mandate. It comes from changing who holds the value. And because the underlying records carry verification of who entered what, when, and in what context, built in at the moment of creation and not reconstructed after the fact, the compliance picture changes too. Healthcare administrative waste and billing complexity costs the U.S. system hundreds of billions of dollars every year. A substantial portion of that is reconciliation, which is just the process of chasing and verifying and matching records across systems to confirm that what was billed matches what was done, matches what was coded. When a record is provably accurate at the moment it's created, that reconciliation problem shrinks dramatically. For a small practice running on thin margins, that is not a footnote. That is the difference between surviving and not. Now scale that up, and the problem and the answer both get sharper. Picture a financial analyst on an acquisition team. Her firm is evaluating a regional hospital network, 4 facilities, a few 100,000 patient records, a revenue cycle operation which is having dozens of people whose entire job is confirming that the system's records agree with each other. She's 3 weeks into due diligence. She's looking at billing data, and she cannot fully close the loop on whether what was billed, what was done, and what was coded all trace back cleanly. The systems don't speak the same language. Some records have gaps in their history. She doesn't know if they were always that way or if something changed. She can't know, so she builds a risk buffer into the model. She flags the uncertainty for her partners. They absorb it on close or they walk. This is the normal version of this story. Every acquisition of a health system built on conventional infrastructure has a version of her situation baked into it. In a human-centric operating model, that situation largely doesn't exist. Every record is independently verified and tamper-proof from the moment it was made. The billing history doesn't need to be reconstructed. It doesn't need to be reconciled. It proves itself at a physics level. Her team doesn't build a risk buffer around record integrity because record integrity isn't a variable anymore. The due diligence closes faster. The risk absorbed on close is quantified. The cost of capital on that deal looks different. For a CFO managing a multi-facility system, the same logic applies every single day. The revenue cycle team that currently exists to verify what should already be verifiable stops growing every time the network adds a facility. That is a direct P&L impact that compounds with scale. But there's a second dimension here, and I want to spend a minute on it because it's where most people's thinking stops short. A large health system is sitting on decades of accumulated records. Lab results, clinical notes, imaging reports, treatment histories, billing records. Right now, most of it just sits there. And when I say that, I want to be precise because most people at this point will think, hey, you can already upload documents to an enterprise AI system and ask it questions. We're doing that. What's the difference? This is the most important distinction we've made so far. When you upload records into a conventional AI system, even an enterprise plan, take your pick on your biggest frontier models, the system reads what it's given and generates a response based on patterns in its training. In short, it's making educated guesses. It's drawing inferences. And at the moment when the stakes are the highest, a patient is in the room, a clinical decision has to be made, that system can tell a clinician with complete confidence which medications are safe for that patient based on general patterns rather than patient's verified record. And it can get it wrong, dangerously wrong. A kidney patient receives a dosage recommendation built for a healthy adult. Fluent answer, catastrophic outcome. The industry has a word for this, hallucination. And it's the single biggest reason AI adoption inside large health systems and just large enterprise systems in general have moved so slowly. The liability of a confident, wrong answer in a clinical setting is enormous. The collective intelligence we're describing here is structurally different. Every record that enters this system carries verified proof of its own origin and integrity. The system isn't guessing. It reads from records that are independently verified and tamper-proof from the moment they were created, anchored to their full context: who made the record, where, when, and in what clinical situation. When the system services a pattern or answers a query, it traces every claim back to a verified source. The enterprise health system stops managing a warehouse of files and starts operating with something closer to a genuine institutional memory, one that can tell you what it actually knows rather than what it estimates. For a CFO, that is operational, real reduction in the cost of compliance, audit, and decision support. For someone evaluating what a well-run health system's record are actually worth as an asset, verified, structured, and trustworthy at scale, that's a different category of asset than what the current model produces. Here's what I want you to sit with before we go. We've been talking about data and systems and records and incentives, but zoom out for a second and look at what this is actually about. The sovereignty argument we've been building on this channel runs across 4 areas of life: your data, your faith, your sense of worth, your physical health, your family. Healthcare sits at the intersection of all 4. When you can't carry your own health history around you, you lose autonomy over your own body. When the system profits from your data without your knowledge, your dignity is being extracted alongside it. And when a clinical decision goes wrong because an AI guessed instead of knowing, the person who bears that consequence is you or someone in your family sitting in that room. And when a small practice doctor can't afford to stay independent because the economics of the current model squeeze him out, your community loses the relational continuity that good care actually depends on. This is why this is not a technology story. It's a sovereignty story. And healthcare just happens to be the domain where that story is most personal. Everything we just walked through, the woman rebuilding her health history from memory, Dr. Webb paying to fund the extraction of his own patient's data, the analyst trying to close a deal on records they can't prove themselves, none of it is the result of bad actors. It's the result of a structure. The current model was built around the institution and the platform. Data lives where the transaction happened. Value flows to whoever owns the system. And we've all made peace with that arrangement because, honestly, we've just never been shown another way to structure it. The human-centric model starts from a different assumption. The person who generates the value should have a meaningful relationship to it. That includes portability. It includes consent and economic participation. And at every level of the value chain records the proof themselves rather than needing teams of people to do it for them. Healthcare is one domain. We're going to walk through others. Every one of them has a version of this same story. A version where the people doing the work, generating the signal, living inside the system, are funding an extraction model without knowing there's another option. Every domain has a version of that woman at the clipboard. The operating model to change that relationship is being built. Communities and organizations are integrating it right now. And the question I keep coming back to is this: if the technology was never the missing piece, what was? We're going to keep building toward that answer.